circumstance, issues related to stress and incarceration from his work with hostages from Iran and from the Vietnam POW era. And Hans Hock is a criminologist who many of you may know has been academic criminologist for over 50 years in upstate New York. So those are folks that I work with. Just so you know, the next slide frames this issue as a long-standing issue. But the insane criminal has nowhere any home, no age or nation has provided a place for him. Next slide. He is everywhere unwelcome and objectionable. The prisons thrust him out. The hospitals are unwilling to receive him. The law will not let him stay at his house, and the public will not permit him to go abroad. And yet humanity and justice, the sense of common danger, and a tender regard for a deeply degraded brother man all agree that something should be done for him, that some plan must be devised different from and better than any that has yet been tried, by which he may be properly cared for, by which his malady may be healed, and his criminal propensity overcome. This was written in 1857 in the American Journal of Insanity, which is the precursor to the American Journal of Psychiatry. It's just so clear that we just haven't really moved from that position. Nobody really knows what to do with these folks. Nobody knew then. Really nobody knows now. It's a very, very sad situation that we're in. That doesn't mean it's hopeless. That just means it's hard work. And I think in my practice, I've been able to get past this a bit. So here's what we're going to talk about. We're going to talk a bit about some basic statistics. Probably be familiar with most of you. Talk a bit about the relationship of mental illness and offending behavior, some sample research, although it's certainly not an exhaustive research study. What mental health treatment providers can do for individuals who are offenders of mental illness, and a bit about how we can assist them through reentry. Next slide. In 1990, one out of just over 200 residents in the U.S. were incarcerated. In 2000, one out of 142. So we've been very successful at locking people up. Not clear that we've been as successful at helping people get unlocked. As of now, there are over 2.2 million people incarcerated, over 4 million people on parole probation. So that means just under 3% of the U.S. population is under some form of correctional supervision, whether they're incarcerated or on community supervision. All these statistics are courtesy of Bureau of Justice Statistics from DOJ. This slide shows this in visual format. Well, you can see the yellow line is jails, and you can see that the jail population has tripled from between 1980 and 2000, from just under 200,000 to just under 600,000. Similarly, the prison population has more than tripled from about 350,000 to almost 1.3 million. Dramatic increases in the jail prison incarceration rate.
And if I can interrupt it for just a second, because we're having some problems with audio. If I could ask once again, for those who have joined us after Dr. Roscoe started with his presentation, if you could please mute your phone. It's *6 to mute your phone if you don't have a mute button. And we will open up the call at the end of the conference call for questions. But for now, if you could please have your phones on mute. And again, it's *6 to mute your phone. Thank you. Sorry about that.
A lot of muting going on, it sounds like.
Yeah.
All right, so the next slide makes this a little bit more clear. First bullet, law enforcement. Every 6.5 minutes, a New York City police officer is dispatched to a call involving a person with mental illness. So that's however many times, 10 times an hour. That's 240 times a day. Multiply that by 365. Many calls involving people with mental illness. At the court's perspective, of 21,000 defendants screened in Hamilton County, Ohio, that's Cincinnati, I think, 11% had a serious mental illness, compared to 5% of the general population. Corrections, many of you may be familiar with this 16% number of state, prison, and county jail inmates have mental illness from BJS. And from the mental health side, the other way around, people with mental illness are more likely to be involved in the criminal justice system. Men in New York are 4 times as likely to be incarcerated, whereas women are 6 times as likely to be incarcerated. So both people who are criminal justice involved are more likely to have mental illness, and people who have mental illness are more likely to wind up in involved in the criminal justice system. It works in both directions. Next slide tries to dichotomize the problems of increased numbers of people getting in, increased input, and difficulty getting out, problems with output. From the entry side, the institutionalization, this is a long-standing, well-known phenomenon. In 1937, British psychologist Lionel Penrose published an article where he studied prison populations and what they call asylum, state hospital, insane asylum populations in 15 countries over 50 years prior to 1937. He found that as the number of people in asylums went up or down, the number of people in prisons went down or up. There was essentially a balance, like a seesaw. This is clearly true today. We've seen a dramatic decrease in our state hospital census in this country over the last 50 years, from over 500,000 state hospital beds in the 1950s to just over 50,000 state hospital beds now. 90% decrease in state hospital bed numbers. And what have we seen in our incarceration numbers? Up, up, up. It's more complicated than that. It's not simply when you close state hospital beds, the prisons have to expand to take those people in. It has a lot to do with access to treatment. So the next bullet in red is kind of the mental health system's problem. It's hard to get into treatment. It's hard to access good care. It's hard to access care that takes care of the illness and its attendant needs, of which there are many. And so the result is people with mental illnesses are arrested at a disproportionately higher rate than people who don't have mental illness. People with mental illness have high rates of substance abuse disorders. We know that folks with serious mental illness have a very, very high rate. Probably 3/4 or more have co-occurring addictions. And we know that addictions can be related to arrest rates, both because of the addiction itself is a crime in this country, and because addiction and the behaviors attendant to addiction can lead to criminal behaviors. There is some evidence that mental illness is related to violence. We'll talk about several recent findings there. And, of course, lots of folks with serious mental illness are homeless. And when it's 22 degrees outside and the person is in short pants and no shirt and sandals, the police are sometimes reluctant to let that person just go away. And unfortunately, sometimes the only place they can take them is jail. On the back end, reentry, folks with mental illness spend longer time incarcerated. They have trouble adapting to criminal justice settings. The correctional environment itself may be pathogenic, particularly if somebody's on segregation for long periods of time. Folks with mental illness have lower rates of parole. They're less likely to be paroled in those jurisdictions that have affirmative parole. They're also less likely to be released with good time because they have a harder time adjusting and rack up more tickets. Finally, when they do get out, there are inadequate mental health services for them to go to begin with, and many community mental health programs are reluctant to take folks from the criminal justice system because of concerns about risk, whether that risk is real or just perceived. And even when they do get out, they have a difficulty with recidivism at a higher rate than even the general population, which has a pretty high rate. The next slide is sort of the remainder of the talk. What is the relationship between mental health and offending, or mental health problems and offending behavior, and then how do we deal with that? Is going to be the next slide. Next slide, we'll talk a bit about several recent research papers. There's an old idea that mental illness was not related to violence. That was an advocacy position promulgated, especially back in the 70s and 80s. But research found that not to be the case, that there are some people with mental illnesses who are somewhat more likely to be violent. And so here is one study, for instance, of 13,000 people in public mental health systems in Massachusetts. Public mental health means Medicaid-funded services or services for indigent people. Of 13,000 people, 28% had at least one arrest in the prior 10 years. Now, I would venture to guess that of the people that are listening to this conversation, I doubt that 28% of us have had an arrest in the last 10 years. And I think if you looked at the general population, you would find a lower number. So overall, high rate of arrest among this population. But if you look at if you parse it out, actually only 5% of that 28%, so 1.5% of the total, 13,000, accounted for 17% of the total arrests. So there's a small number of people cycling in and out, getting arrested frequently. And I think that compares to certainly my experience in both jails and hospitals. We see the same people over and over again. What we are not seeing is everybody with mental illness coming in once. We are seeing a lot of people, or a small number of people coming in a lot of times. The next slide looks a bit at studied the relationship specifically of schizophrenia and found that having schizophrenia did result in a somewhat higher rate of criminal conviction. Now, what was interesting about this study is other studies previously had found that if you account for addiction and substance abuse, the relationship of mental illness and violence kind of went away. It was really the finding that lots of people with mental illness had substance abuse, and it was those substance abuse that seemed to be more related to the offending or violent behavior. And this study actually separated out and found the opposite, found that, well, it's not that simple. That there are some people for whom the addiction is not the factor, it's really the mental illness that seems to be the precipitating factor. And then finally, a study from Sweden found that people with schizophrenia account for about 5% of violent crime. Schizophrenia, just if you don't know, it has about a 1% prevalence rate in every culture. So a five-fold increase representation among violent crime for schizophrenia. Sweden is, like all Scandinavian countries, keeps excellent data, nationwide databases of lots of things among the mental illness and crime, and so they're able to do studies there that we really can't do here. What does that mean? Ultimately, what that means is a couple things. One is, you can go to the next slide. It's not so clear that in fact, it's clear that not everybody with mental illness is violent. What is clear is that there is some relationship between mental illness, especially severe mental illness, and offending behavior. Now, caveat: I do not want you walking away from this talk thinking that everybody with mental illness is about to become violent, because it's just not true. For every show at Virginia Tech, there are hundreds and thousands of people with mental illness who manage their mental illness, who take their meds, who don't become violent, who are not involved in criminal behavior, and who are not going to be involved in criminal behavior. However, there is a small number of people, and I don't know about Joe, I don't know the story any more than what I read in the paper, but there is a small number of people whose mental illness, especially when it's confounded with addiction and poverty and homeless and inadequate services, there's a small number of people who become violent, particularly when they're acutely ill. Those are the folks that we have the trouble dealing with, and those are the ones that kind of make the headlines. What are the implications? Individuals with mental illness, next slide please, have high rates of incarceration and arrest, poor adjustment to incarceration, so they tend to have difficulty following rules. They tend to have difficulty staying on the right side of the line or showing up at the right time for meals or medications. They tend to get tickets because they cross those lines too much, both the real lines and the perceived lines. Because they get tickets, they are more likely to stay longer. They're more likely to go to SEG. Segregation itself can make mental illness worse, can exacerbate mental illness. They're less likely to get bail or recog. If no place to live, and we know that folks with serious mental illness often are homeless, then it's very hard to get bailed out, even with very low bail. They have a reduced chance of getting parole once they get convicted and wind up in prison. Parole commissioners are very wary of people with mental illness. They have a higher likelihood of maxing out, and in many jurisdictions, if you max out, serve day for day, you leave with no supervision. There's no mandate for you to attend treatment, and that leads to a high likelihood of exacerbation of illness, return of illness symptoms, and unfortunately, return to the criminal justice system. And if they are on mandatory supervision or parole or probation, they have a higher likelihood of getting violated because they have a harder time getting to appointments on time and meeting all their obligations. All right, next slide. What is a well-meaning health provider to do? Men will always be mad, and those who think they can cure them are the maddest of all. The point of this is that it's very difficult to think of mental illness and cure in the same sentence. We very rarely can find a cause of mental illness that we can cure. What we do is management. Now, the most common cause of admission to state asylums in the early 1900s, 1910s, 1920s was a disease called general paresis of the insane, which is the end stage of syphilis. And then when penicillin was invented, syphilis became a treatable illness. So all those patients got treated and cured. They're no longer mental illness patients. They're no longer psychiatric patients. That's now an infectious disease, not a psychiatric problem. What we have left are the diseases that don't really have cures. Diseases like schizophrenia and bipolar disorder, just like hypertension, diabetes, cholesterol, are illnesses that we manage, not illnesses that we cure. We don't think about cure in these illnesses. What we think about is management, and that is what we will talk about from here on out. There are some ways that we can treat the offender with mental illness. What are some basic principles? And when I say treat, I don't mean treat as in I'm a doctor treating a patient. I mean, how do we just treat these people in order to help them re-enter society? First of all, a lot of this is a little bit like what you learn in kindergarten. Respect for the person. These are human beings, just like everybody else. And they respond very well to respectful approaches, which is not something that is often taught in increasingly in medical school, but it's very difficult to get this across when somebody is acutely ill and acting violent. Respect for the person. One of the things I've done throughout my practice is always call people Mr. Jones or Miss Smith, and I've had people tell me you're the first person who ever treated me with that respect. Everybody else called me by my first name. Basic needs, very important. If somebody doesn't have a house or money to get food or anything like that, it's very unlikely that they're going to participate in treatment or take medication or do any of the other things we want them to do. The basic needs come first. We have to attend to those. Integration is extremely important. Working together is what I mean by that. If we don't work together, if we don't integrate our efforts, then we run the risk that, Joe Blow on probation, who's supposed to be keeping his probation appointment at 10 o'clock on Mondays, is also supposed to be keeping his psychiatrist appointment at 10 o'clock on Mondays. Well, if we don't work together, we're not going to know that, and the person will get violated somehow or other. That's a very bad outcome. It's much better if we integrate things and work together. We have to, on the other side, accept reality and our own limitations. We can't save everybody. There are going to be people who don't do well. My practice has always been to think about that as a therapeutic issue. If things are not working out well, I've always tried to see that as a treatment issue. How do I improve treatment to improve this outcome? How do I modify my treatment plan to make things work better? So I'll offer hospitalization, or I'll offer change in medication, or things like that. But eventually people can say, no, I don't want it, and I know I'm going back to jail, and I'd rather be there. And I have to say, okay, I can't fight you. The way I dealt with that is by sharing coercion and caring in my practice, by using coercion in the act of caring for someone and using a caring approach while I'm being coerced. Coercion is part and parcel of working with this clientele. You can't get away from it. It works pretty well. I've worked very effectively with probation officers in the past, where we share the caring and the coercion, where we work together and sometimes play good cop, bad cop, sort of split it that way. Works extremely well. It's a bit controversial among mental health providers who often don't want to be coercive or don't want to be seen as being coercive. To me, though, if I can keep somebody out of the hospital, not out of the hospital, out of jail or out of prison, jail is certainly way more coercive than my clinic, in my opinion. So I work very hard to do that, to balance those two sort of poles of treatment. All right, what are some mental health treatment and services? This is not an exhaustive list. I'm sure I left some things off here, but some things that came into my mind as common things that I use in my practice. Medications, of course, for most folks with serious mental illness, medications are a definite necessary component of treatment. For many people, none of these other things can be effective if the person is not stable, and the way to get the person stable is through medication treatment. So it's almost always going to be a core component of the treatment plan. Psychosocial rehabilitation, this is typically outpatient, but can be provided in other settings. This is the idea that folks with serious mental illness, particularly those who've been in institutions for long periods of time, need to learn how to be in the community, need to learn how to manage their lives and their illnesses in a community setting. Lots of services around addiction, around assertiveness training, similar to what may be provided in some therapeutic communities, for instance. Residential services, of course, we talked about housing before. If folks don't have housing, many of these other things are falling by the wayside. There are some residential services that are in and of themselves therapeutic residences or rehabilitative residences that are provided by mental health provider agencies. Others are care providers that focus more on support while the person goes elsewhere for treatment. Integrated treatment for co-occurring diagnoses. This is very, very important. Many communities don't have this, and if you are in a community that does not have integrated mental health addiction treatment, it's very important to lobby for it. In fact, if you're in the criminal justice system, your lobbying is often much more effective than our lobbying, because legislators and people with the purse strings often see our lobbying as self-serving, guilt-oriented. We're just looking for more money for treatment. Whereas your lobbying is seen as much more objective. Very important to have integrated treatment. If you don't have integrated treatment, you leave the responsibility for integrating multiple treatments in the hands of the person least able to integrate, which is the patient. It's a big mistake. The evidence is very clear that integrated treatment is more effective, that integrated treatment is more useful, and has better outcomes. I include here other things besides substance abuse because so many of these illnesses are endemic in our population. HIV, other medical problems like hepatitis C, diabetes, hypertension, cognitive deficits like mental retardation or head injuries, things like that are very, very common, and finding a way to deal with all those things together is important. Many of my patients don't like to go to the medical doctor, don't even have a medical doctor, and I have to struggle with my own ability to treat their medical problems, but also to try to get them into specialty care to manage those problems. If those problems aren't managed, they may precipitate worsening mental state, which may precipitate inability to manage their release plan. Vocational services, many folks want a job, not everybody, but many. Lots of probation orders require people to have a job, for instance. That can be difficult for some people with serious mental illness who may not be prepared to work in the competitive workforce. Lots of community mental health providers have access to rehab services. I know there's somebody from DOORS, which is the Maryland remote rehab entity that provides vocational training and placement for folks, as well as supportive employment. Those are some of the modalities available to people with serious mental illness to help them enter the workforce. Some folks don't want to work, but for folks who do want to work, it's very important to try to find ways to get them successfully into the workforce. Case management helps integrate services that are not integrated. So case managers are very helpful in giving people basic skills, learning about time management, learning how to keep appointments, learning how to ride the bus system or the subway system in the community, which I had a patient who got out of federal prison after 10 years, and he was terrified he'd get on the wrong bus. And he eventually became very depressed within just a couple months, wanted to go back to jail. So case management was very helpful in helping him understand how the bus system works. Psychotherapy, group therapy, these are modalities that can be extremely useful for folks. I'm not talking about Sigmund Freud, Woody Allen, couch therapy primarily, but more supportive therapy, help in understanding in relationships, working with communities, understanding how to manage stress, things like that. Peer support is something that I think we often overlook. Peer counselors, peer support specialists can be extremely helpful in the sort of, I had this problem and here's how I specialists can be very helpful, particularly folks who've had mental illness and been in the criminal justice system and who are in a recovery phase, who can help guide their peers. Very, very useful. The next slide just is the concept of superintegration, which is the integrated treatment as mental health and substance abuse. Superintegration, in my view, would include the correctional system, include the community supervision specialists, the correctional officer population in a jail or a prison. We all have to be on the same page. We all have to share our mission or vision about what we're doing. Next slide is an example of this kind of collaboration model. This is a model I developed with Rich Feldman, a federal probation officer in Baltimore. The left side is goals of the treatment provider. We provide treatment services, evaluations, develop a working therapeutic alliance, aim to prevent further sickness. The right side goals of the probation officer is to maximize his database, make sure he understands as much as possible about the offender, to ensure that supervision is practiced effectively, mainly focused on the public safety side. What are the shared goals? Again, public safety, minimize risk. That's a goal that I share with the probation officer when I'm working together with the probation system. We both want compliance with appointments, compliance with medications, make sure that the symptoms are under good control. And essentially the main vision is that people are going to be re-entering the community, remaining in the community, and successfully staying in the community, and avoiding further institutionalization. Now, my personal preference is if institutionalization is necessary, it's much better to have it in a hospital. And so I would work with the PO in various cases. We had one guy who had bipolar disorder, cocaine addiction, and was a bank robber. And he kept going back to federal prison, getting high on cocaine, and getting married.
Okay, we have a little bit of an audio issue.
All right, maybe that's a little better.
Okay.
One day he came in and he was looking a little manic, swore he wasn't using cocaine.
Please use text telephone.
Swore he was taking his medication.
BPY call. Please use text telephone.
Anybody know who that is?
BPY call. Please use text telephone.
I'll just try to block that out.
Okay.
And what we did, we sat him down. He didn't want to go in the hospital. He said, I don't want to be in the hospital. I'm fine. The PO came in and said, well, if you don't listen to Dr. Roskis, you're going to go back to prison. And we talked to him. We finally figured out he didn't want to go to the hospital because it was like check day the next day. And he said, if you live in my neighborhood, you're not there when your check comes. Your check isn't there when you come back. So we said, well, what if we could get you into a day hospital? We could just ratchet up the level of care a bit. And he said that was fine as long as he'd be on when the mail came. And so we did that, and he did fine. He didn't have to go back. So we were able to keep him in the community. Hospitalization is not a bad outcome, in my opinion. Jail or prison, new arrest, new offense, that's a bad outcome. That's what I'm trying to avoid. And that's what the POs are trying to avoid. So this paradigm really plays that out. And you can reiterate this at any level, with police, with courts, it doesn't matter. There's always some shared goals. All right, next slide. Gene asked me to include some information on benefits and money and how you get free meds for your clients. Not easy. It's very varied by jurisdiction. There's no one answer to this question. In Maryland, the way we deal with folks who are not yet active Medicaid recipients is we have a concept in our Medicaid law called gray zone, the way Medicaid is managed. Gray zone means essentially you've applied for and are presumably eligible for Medicaid, but it's not active yet, and certain target populations can get services as if they're on Medicaid, and those providers get paid as if they're on Medicaid. And one of the conditions is recent release from a correctional institution. So it's a way of getting folks who are coming out of jail or prison access to mental health services even before they have Medicaid. New York has a similar model, New York City, called the Medication Grant Program, which is more limited than gray zone. What it does is it allows folks to get psych meds and the services against like that, like a psychiatric visit or visits while the application for Medicaid is pending. There are some resources here listed. These websites are primarily websites that list drug company indigent patient program websites. They're good but not great. You have to go to those things and apply for each company. If somebody's on 3 different meds, you have to usually fill out 3 different applications. It can be a bit of a pain, but you get free meds at the end for the patient, or the patient gets free meds at the end. The downside is that these are only working for medications that are still on patent. So many people coming out of jail and prison are on the low-cost, older, generic medications, which are not really accessible by Kansas. So that can be a problem. The good side is they don't cost much. The problem is if you don't have $10 is too much to afford. It's a problem. I don't have any easy answers. The way to deal with that, the way that many jurisdictions deal with that, is by working with the mental health agency in the county for accessing like a flex fund system or developing a flex fund account where you can get free meds given to you that way, or low-cost meds where the county picks up some of the budget. But the county's got to have money for that, and not all counties do. There is a beginning of some legal advocacy over the last 10 years or so that in case law that says if you are a jail or a prison, you have some responsibility for assisting inmates in getting benefits or services prior to release. Social Security Administration has long allowed applications prior to release. If release is in the next 90 days, or is anticipated in the next 90 days, you can apply for Social Security benefits, SSI or SSDI. Many inmates with serious mental illness are eligible for particularly SSI. If you get SSI, that brings with it Medicaid. So it's a good resource. Jails and prisons can develop institutional agreements with SSA. Wakefield v. Thompson and Brad H. are 2 cases. Wakefield v. Thompson is a federal appellate case that holds that a prison has some obligation to provide medications after the person goes out. There's some period of time where simply having been released from prison is not enough, because you can't just go out of prison one day and walk into the medical office the next day and expect to get treatment. I don't know how your doctor is, but if I call my doctor today, I'd be waiting a month for an appointment. And the same is true, and maybe more true, for people who don't have any benefits. So if you get out of prison, if somebody's getting out of prison, the prison has some obligation to provide them with medication. Brad H. is a case that's somewhat similar to Wakefield. It's a class action settlement. It requires the city of New York to provide certain discharge planning services to folks in the jails of New York City, including applications for benefits as well as medications and appointments at providers in the community. Okay, next slide. This is a bit about stress and release. We're all familiar with the notion of stress of incarceration. Getting locked up can be very stressful, but getting out can be very stressful as well. This data comes from a study from Mark Renzema, who studied people getting out of prison. And what he found was that stress, which was a bit high at the time of release, dropped in the first couple weeks and months after release, but then gradually increased as months went by. The measures of stress used were things like blood pressure and adrenaline levels in the blood and stress hormones and things like that. And they all went up after a few weeks and months in the community. And the reason for that, I think, is fairly clear. Folks are very happy initially to be out, but then after a while they find out it's not so easy. And that's exactly the time when we're backing off. When mental health providers are saying, oh, I've seen you 3 times in the last 3 months, you're doing okay, I only need to see you every 3 months now. Or when probation agents are saying, you've been coming in every week for the last 8 weeks, I think I only need to see you once a month now. That's exactly the time that this stress is starting to build, and we're backing off, and I think that's a mistake. The next slide is kind of sort of spells this out. There's a need for programming that crosses the instant of transition. We have to think about reentry as starting well before the person walks out the gate. We have to think about it as starting weeks and months before. There's a need for consistent supervision intensity that recognizes that release is stressful, and it's not always immediate stress, but there can be a delayed response for many of our clients. And we need to think about how we work in our communities for developing other support systems. Should there be hotlines for offenders, specialty hotlines, or prisoners' aid type of support groups? phases of the criminal justice system. So, for instance, police in Memphis for many years have had a CIT model, crisis intervention team model, where police officers receive special training on mental illness. They will work with them and are able to avoid bringing many of them into the criminal justice system in the first place. They have a very low arrest rate. They can keep people out. That's in part due to a partnership with mental health providers. They have a partnership in Memphis with the emergency room there, and they can successfully move people into treatment when treatment is what is needed instead of arresting them. What I see in my state, even in counties that have CIT models, is that police sometimes don't do that. That some of our clients are basically arrested and charged with being mentally ill in public, loitering, trespassing, urinating in public. When the cop approaches them, then they resist arrest, which I might do too. So then they ratchet it up a bit and they assault the cop. They wind up arrested. Maybe they have to be arrested, but I think if cops have better understanding of folks with mental illness, that arrest rate goes down. And we've seen some of that in Maryland, and we've seen some of that elsewhere as well. Mental health court models, these are specialty courts, problem-solving courts. They were developed out of the drug court model, based on the theory of therapeutic jurisprudence, which is the idea that the court system, the criminal justice system, can have therapeutic outcomes. That it's not just about punishment, but it can also be about therapeutic aims, helping people improve their lives using a positive reinforcement model. Typically, mental health courts work with lower-level offenders, misdemeanors, lower-level felony offenders. Most of them are voluntary. They require the agreement of the defendant to enter into the mental health court. One of the problems is it's somewhat of a coerced voluntary. If you don't do it, you're looking at 3 years, which is how much of the court system works, of course. But also, many of them require a guilty plea. And the outcome is if you come to mental health court every month for the next 2 years and successfully complete your treatment and stay in treatment and participate in the program, we'll get rid of the case. We'll expunge your record. Well, that can be hard. That can be hard for people, and some people would rather not file that guilty plea. Not all mental health courts require that. Some will just defer on guilt and then eventually not prosecute the case. But some require that guilty plea. So it's a bit of a controversial model. There's some evidence that it reduces criminal justice costs. A recent study from the Rand Corporation found that it reduced criminal justice costs even beyond the expanded mental health system costs. So maybe a cost-effective intervention as well. So talk to the Reentry program. This is a program in Maryland where the Maryland DOC has a specialty mental health prison at the Tucson institution that brings people in 6 months prior to their planned release, works with them on release preparation issues, a lot of addiction work, a lot of work on assertiveness training, work on sort of basic life skills, budgeting, stuff like that. In addition, case managers from Baltimore City come in and begin to engage with the person prior to release, and then stay with the person for several months after release. So manage that person throughout the time from pre-release into the community and beyond. It's been very effective, a fairly low level of recidivism, and good engagement in treatment. U.S. Probation Specialist Model. This is a model that I work with in the U.S. Probation Office in Baltimore. The Federal Probation Office has had specialist probation officers who have carried mental health cases and a reduced caseload. They have other specialties as well, sex offender caseloads, addiction caseloads. They have PSI specialists, pre-sentence investigation specialists. So they've developed their own internal specialists, and my role was to be a mental health provider as a forensic specialist working with those cases. Works very well because we shared that vision, as we talked about before. And then within the mental health system, there's a relatively new model called FACT, Forensic Assertive Community Treatment. Assertive community treatment has been around for a long time, but this FACT, the forensic aspect of it, is a relatively new innovation. Probably the first one was Project Blink in Rochester, New York, which focuses on highly intensive community-based treatment services, including mental health, addiction, some primary medical care, peer counselors, all within one program, all of whom work with the client ACT programs or FACT programs actually provide space to a probation officer to come and work with the clients on site rather than expecting the clients to go into the probation office. So that can be a very effective collaborative model for folks who have a hard time getting places, either because of there's not a lot of public transportation in the community or because they just are not psychologically equipped to get around. I want to close with a couple of quotes. The trick is to see the human being behind the rap sheet. Always hard for us to remember, particularly with some of our clients who committed pretty heinous offenses. Then the next quote, always give the patient hope even when death seems at hand. This is a quote I like because it's from a surgeon from the 1600s when surgeons didn't have a lot of good things to offer. And anesthesia was like the bullet. There was no such thing as antisepsis or infection control, and basically all they could do was amputate, and even then the patients often died. And still, this guy was giving people hope. We have a lot more a lot more things to offer people, so certainly we should be always hopeful. The next slide is the brief bibliography, just the 4 studies that I cited in this talk, if you want to look those up. And I am ready to open up to questions, discussion, comments.
Again, I wanted to let everyone know that if you press *7, you can unmute your phone. If you have a question, I ask that you identify yourself, say your name and where you're from, and state your question. Again, it's *7 to unmute your phone. And, we have a couple of minutes to answer any questions that you might have. I see that Monique Hughes has a question.
Yes.
Go ahead.
Can you hear me?
Yes.
Oh, hi. I wanted to know, I am Monique Hughes, and I'm serving as an AmeriCorps sister with the Texas Ex-Offender Reentry Initiative. And we're right now, myself and the other sisters are looking for these types of services for persons with mental health. Do you have any type of avenue we can take to finding those in our area, in Dallas County?
Have you worked with the Texas Council on Offenders with Medical and Mental Impairments?
No, I've never heard of them.
Okay. You need to hear of them.
Okay, that's
it's TCOOMMI. Let me just look on my computer here for a second. I have some stuff from them.
okay.
And I'll get you the exact name as soon as I can find it here. It is called the Texas Correctional Office on Offenders with Medical and Mental Impairments. This is an organization run out of the Texas Board of Criminal Justice for many, many years, 20 years. And they focus specifically on offenders with mental illness and also offenders with medical problems since 1987, so 20 years exactly. Funded by the legislature. The legislature has expanded their funding recently. If you, my email is at the end. If you email me after the talk, I can definitely hook you up with somebody there who can help guide you.
Oh, that would be wonderful.
Sure.
Thank you.
Do we have any other questions? If not, we'll be wrapping up this event and this session. I just wanted to highlight a couple of other things. As I mentioned at the very beginning, the webinar series is part of a collaboration that the Corporation for National Community Service has with AmeriCorps Vista programs and Weed and Seed sites. If you'd like more information on this initiative as well as just general reentry information, the current slide has information on how to join a reentry listserv that has regular postings and updates with information, and also the website for the corporation, the resource center of the corporation, which has recorded versions of our webinar series. And this webinar will be recorded and will be up in the next day or so, and be available to play again if it's something that you want to refer to a colleague or want to hear the session again. Dr. Vasquez did mention that he was okay with giving out his email address. So if the current slide that is up has his email address for those of you who would want to contact him directly. If you want a copy of this presentation, it is available through the link that took you to this presentation online. You can download it using the meeting password, which is attend. I can also email it to you. My email address is also listed on the current slide, so you can go ahead and email me if you want more information. If we don't have any other questions, we'll go ahead and wrap up. I just want to give another minute to allow for questions. Monique, did you have another question?
Yes. Do you also work with juveniles that suffer with mental health issues?
Do I personally work with juveniles?
Mm-hmm.
We do have at our hospital a small number of folks coming in who are older juveniles. They're generally in the 18 to 21 range, but are involved in the juvenile system.
Mm-hmm.
I don't particularly work specifically with them. One of our psychologists really focuses more on them.
Okay.
I am not all that familiar with the juvenile system. It's in Maryland. It's a bit disorganized. So
okay.
I'm certainly not an expert in that.
Okay. I'll be emailing you.
You bet.
Thank you.
Thank you. Do we any other questions? I don't see any other hands. If not, I thank you. I thank everyone for your time, and you will be receiving an email from me shortly, just with a quick survey to make sure that this was helpful and to see how we can improve these sessions in the future. Thank you again, Dr. Oscus, and thanks to everyone for participating. I hope that you got a lot out of this.
Thank you.
Thank you very much.
Thank you.